that were coming into his emergency room. So what he knows, being an ER physician, is that you really do have a large subset of people who are coming in that need care, right? They have something that's life-threatening and or limb-threatening. And then you have two other buckets. So it's really these folks that that maybe they have something that's urgent and they're unable to access their primary care physician or unable to get into an urgent care facility, and so they go to the emergency room, or they really don't know where else to go, or they're using the emergency room as a more convenient option for care. And if you look at this breakout, it really shows the four primary reasons why Coloradans are using the emergency department for non-emergent issues. So what we wanted to do is we wanted to see, can we solve for those two subsets of people, those people who have urgent but not emergent, as well as the folks that have limited access or don't know where else to go. So what we did is we partnered with South Metro Fire Department to integrate into their 911 system for folks that were assessed at a lower level of acuity. So if I call 911, there's a series of questions that are asked about my case, right? What's going on with me? And that assessment is essentially bucketing you as a level of acuity. So for low level of acuity, which are called Alpha Bravo, we would dispatch out alongside the ambulance. And the reason we started the integration that way is we really wanted to see, number one, are people receptive to receiving care outside of the walls of the hospital? So are they comfortable being treated inside their home? Number two, what are the clinical supplies that we really need in order to provide a lot of the ER capabilities inside the home? And what are the clinical staff that we need as well? And then the most important question, I think, that we were trying to solve for is, what are the quality outcomes? So are we just adding another big piece to this puzzle of healthcare, or are we actually solving a major issue and creating better quality outcomes for patients, right? So we ran this proof of concept for 18 months. We saw 400 patients, which was 96% of the cases that we dispatched out on. And then you can look at some of the numbers. So some of the big things that we saw in terms of success were we had no adverse outcomes, which is unheard of, really, in the healthcare space. We had less than 2% bounce back rate to the emergency room. And we had a cost savings of close to $1 million. So we knew that there was something here within this type of model. So what we did with that data is we took it to both payers to see if they would cover this from the insurance side, this new type of treatment in the home, as well as we took it to investors to see if there was a way that we could provide care not solely through the 911 system, but where people were accessing us directly. So what happened is we created DispatchHealth in August 17th of 2015. And this is really just in the Denver metro area right now, very, very new as well. But what we were looking at is what Mark Bertolini, the CEO of Aetna, always says is convenience is really the new quality. So how can we create a convenient solution that provides better care for patients, and we're meeting the patients where they're at, rather than the patients really going to the emergency room and waiting on the physician's time. So if you look at the history of house call services, 1930s, 1940s, it was pretty high, right, where physicians provided the majority of care inside the home. And the reason why we saw this significant drop to less than 1% has a lot to do with it just didn't make sense after a while for physicians to be going to a lot of different locations. They weren't able to see as many patients at any given point in time, so they created a central location where the patients came to them. However, this beautiful thing called technology in 2016 is allowing us, again, to provide care outside of the walls of a physician office and or a hospital and directly in people's homes. And what that does is, again, we're creating a convenient solution for patients. We're creating something that's on their time, as well as there's a significant cost savings associated to it. And the reason for that is because you're taking the overhead specifically of the hospital out of the equation. So how we integrate into the current delivery model, we're creating what we call our new acute care model. You have of course, a patient population, or really just the population of people who need care. You have 911, which still functions as it should. We are still integrated with South Metro Fire Department, and we'll continue to integrate with fire departments across the board, I think, if they're interested. And then you have us. And you have telemedicine and you have nurse advice lines. So let's go through these. So the way that DispatchHealth works in conjunction with telemedicine. So there are cases where it makes a lot more sense for a telemedicine type solution, right? Somebody thinks that they maybe have like an ear infection or a sore throat, something that's pretty minor, that a physician can do via Skype. But there's cases where you have a laceration or someone's dehydrated, they have a feeding tube that's popped out, something more severe, they have a catheter that maybe needs to be replaced, or they need a catheter placed for urinary retention. Those are the cases where you really need to send a team out and be on the ground in the home. So that's what we do. We send a team directly to the house for acute care situations, and then we work really closely with individuals' primary care physicians as well as their existing care team. So when we look at an existing care team, it's anywhere from the PCP to you all, being that you're in the home, you're working right alongside those individuals, you know them really well, as well as medical home health. We look at that whole model. If someone's in a skilled nursing facility, we have the ability to work with them in there. Who we send out is actually, it's a nurse practitioner or a physician assistant. They are required to have 5 years at a minimum of ER experience and have some emergency medicine board certification. And then they're accompanied by an EMT. So you always have 2 people on the ground in the house, and they're supported by what we call a virtual physician who's available for phone consultations, as well as can see our electronic health record. So you have 3 people that are serving our patients at any given point in time. And the way that we see this working in an integrated care delivery model is that DispatchHealth, we really end up serving this in between of the hospital and the existing medical home that a patient has. So everyone that's involved in that, right? Primary care, specialty care, pharmacy, behavioral health, home care services, where you all really fit in. And then we are working really closely with hospitals as well. They know their patients that are at high risk when they're being discharged from the hospital, and so we work with case management to make sure that they're sending them to us, or they know that when they go home from the hospital, they have an option that will come to them rather than them going back into the hospital, where again, it's just a very expensive place to receive care. So early success to date, we do have payer relationships. We just signed Kaiser, but that's for Senior Advantage. We don't have Kaiser for the commercial population. We can also take Cigna, Blue Cross Blue Shield, which Anthem, Aetna, United, Humana. We did officially get Denver Health Medical Plan, which in the Denver area, that includes all Denver employees, I think city employees, Denver Health employees, it's the firefighters and then I think it's like Denver Public Schools as well. So that'll be a big one. And our cost, I should say, so this seems like an expensive model, but it's pretty reasonable. So in order to use DispatchHealth, you're looking at $150 to $300, which is comparable to urgent care versus the $2,200 you could be looking at if you go to an emergency room. And then we do bill insurance directly for care provided. We also have Medicare, Medicaid, and TRICARE. And I would say 65% of our population right now is Medicare. And then we're looking at the remainder of that. We do see everywhere from a 3-month-old to end of life. So we have a younger population where they fall into this commercial payer mix. We recently received Startup of the Year for Denver, which was exciting. I think Colorado, we were Startup of the Year, which was exciting. We have a Net Promoter Score. I looked at it this morning. It's actually 93 as of today. And what that is it's how likely are you to recommend DispatchHealth to a family member and or to a friend. And if you look at the industry average, it's about 30. To give you an idea, Apple is at 70. So to be at 93 is pretty incredible. We're excited about that. And then we've generated over 2 million now in cost savings, and we're seeing less than a 5% bounce back rate to the ER. And the reason why we look at that bounce back rate is if you look at the national average, it's about 25%. So 1 in 4 will go back within 30 days for a same or related symptom. Not great. We do have some pretty incredible patient testimonials, and that's one of the great pieces of my job is I get to speak to a lot of our patients that have experienced our services and share their stories. This gal, she actually had a 3-year-old. They were having a dinner party. The kiddo had a nursemaid elbow. We were able to go out, treat on site while her entire family was in her house. So it saved them a lot of time, and he was a lot calmer because we were treating him at home. We have quite a bit of press coverage, and then what we're excited about is this technology. So honestly, we wouldn't be able to do anything that we do if it wasn't for the technology that backs our company. We do have 3 ways that people can access us. So they can call us directly, they can access us through the web, and that's what you're seeing right here, or they can access us through our mobile app. So we have this for both iOS and Android. What it does is it's very similar to Uber. It geolocates you. You type in your symptoms, you essentially dispatch provider, and then you see who's showing up to your door. So it's a good experience from that side. And then you can see really quickly just how our providers are actually currently operating. So what this screen shows you is the provider dashboard. They can see how many patients we have in queue, how many patients we've accepted, who's en route versus on site, how long the patient has been waiting. So we're looking at wait times frequently. Right now our average is about an hour. And then we can see all the care that was completed. We do not archive our patients until follow-up is fully complete, meaning that the PCP has notes. We've looked at their 30-day outcomes within Korea, so there's a lot of back-end stuff that happens. And then we, in a very creepy way, have geo-targeted all of our cars. So we know where any car is at any point in time. We can see how long they've been on site. So if they stop for lunch, we know that they're stopping for lunch and where they're at during that time. But what that allows us to do is really see if we have Denver Metro is, again, where we've started. So if you think I-70 down to Castle Rock and then the E4C 470 boundaries, it's still a really large area to service. So if we have 3 vehicles on the road, we want to see, and we have a call come in from Parker, it doesn't make sense for us to send somebody who's really far north. That's further south in the Denver area. So we look to see who makes most sense. And then we do have a lot of data that we're capturing as well. So we have a pretty comprehensive BI tool. In terms of how we're acquiring patients, it's all been through very specific partnerships. We think partnerships are key to our success. We do have a health system partnership, and in the Denver area, it's with Centura, where we're embedding with all of their hospitals. We're working really closely with their nurse advice line. So there is protocols in which nurse advice will send dispatch out instead. Senior care is a really big piece. We also have stuff, a solution for employers that are taking risk on their employee population and payers. And then we have, I'm not even able to see, but we do home care as well. So there's quite a few partners that you can see there. This goes through all the injuries and illnesses that we treat. So we do carry a CLIA certified lab on us, so we can do rapid infectious disease testing on site. We can do UAs on site in real time, stitches. We've seen anything from minor bone breaks to neuro complications where someone has changed their demeanor quite a bit. We saw a lot of flu this last season and pneumonia. We do work with a company called Pacific Mobile, so if someone's homebound and they need x-rays, we can send out Pacific Mobile to do x-rays on site. And yeah, there's a number of things. This gives you an idea of what the full experience looks like. All of our nurse practitioners and PAs wear a light gray scrubs, and then our EMTs are wearing navy blue. That's all purposeful by design for making sure that people know who we are when we're coming in, especially if we're in like a skilled nursing facility or any setting where additional providers are providing care. And then all of our patients receive a discharge folder, and the discharge folder is pretty comprehensive. It includes, of course, who you saw, your diagnosis, and follow-up instructions. It also includes a one-pager that explains insurance. And the reason we did that is we receive questions, and I think in general, it's hard to understand insurance as just as a consumer, right? As a member of any given plan. And so we've made it as simple as possible so that people can understand what it means to have a deductible versus max out of pocket, and they can figure out the equation of what they'll be responsible for. So that comes in every discharge packet. And that's all I have. So I think at this point I'd open it up to questions.
Melanie, are you seeing, with the busyness of a primary care office or even some of the specialty offices, are you guys getting calls? It seems like, if you have something, it doesn't seem non-urgent, but it seems like doctors are sending people to the ER if they can't be seen in the office. Are you guys seeing more of those calls coming to you now, or?
They're starting to. So, I think one of the biggest challenges that we've run into is you have to really re-engineer the way that people think and have historically acted. So keeping us top of mind is key. I will say we've noticed now that Fridays, Saturdays, and Mondays are some of our busiest days. And the reason for that is we're receiving a lot of primary care and specialty referrals. So they can't get their patient in, it's the end of the week or it's the weekend, and we're getting calls from the on-call provider beginning of the week, and they have patients that maybe waited the entire weekend and are really sick and they can't get them in. So that's when a lot of those referrals come in.
Okay. I would open it up to questions on the group there. I'll unmute people so you can go ahead and ask any questions if you're out there. Do you see yourself continuing to expand into other carriers?
Into other areas?
Yeah.
Yeah, I think so. This summer, our goal is to expand summer, early fall, we'll say.
Okay.
Our goal is to expand all the way up to Boulder.
Okay.
Out of the Denver office, which will mean the Thornton, Arvada, that entire area that's still not really outside of Denver.
Yeah.
Then our next big market, I think, for Colorado will be Colorado Springs.
Okay.
Our board is looking at expanding us outside of the state of Colorado by the end of this year. So we will have another office outside of the state of Colorado.
Okay. What do you see as your biggest challenge currently?
I think I kind of touched on it a little bit, but it's really that how do we stay top of mind for people? I think people are just accustomed to automatically either dialing 911 themselves, immediately going to their emergency room, or they're advised by their physician to go to the emergency room, right? So it's how do we really push ourselves so that we become another option that people are always referring us to rather than immediately going to the hospital.
Now, I know EMTs can do, say they had an experience, summer's coming, they have a heat stroke, they're at their house. Can you hang a bag and you're doing IVs in the house?
Yeah, IV fluids. Yeah, we do IV fluids. We can do IV antibiotics if necessary. We do travel with a small pharmacy is what we call it, so that we can provide first dose while we're on site. The only exception to that is we don't provide any pain medications, so no IV Dilaudid or fentanyl or anything of that nature. A lot of that has to do with, one, we haven't seen a big need for it, and two, it's for safety of our providers.
Yeah.
We can prescribe out if pain medication is necessary or any other meds are needed.
You mentioned kids. Are you guys seeing, with all the athletics that kids are involved with, like a soccer field kid twists an ankle or something like that? Are you getting calls out to
soccer fields? Yeah, we're starting to.
Okay.
Yeah, and I think with this summer that'll catch on even more where we're at playgrounds or wherever the kid happens to be.
Yeah.
We're starting to see things like, we went through the whole flu season, and now we're starting to see sports injuries. So there are lacerations, strains, sprains, We're seeing concussions, things of that nature, again, for that younger population, those kiddos.
Okay.
Yeah.
Makes sense.
Yeah, yeah.
Along those lines, what was I thinking there? Shoot, just went right out of my head. Any questions from anybody that's on the line out there? How do you see the interaction with home care? How do you see that as a fit for your organization?
Yeah, I think with home care, you all are in the home. You know your clients really, really well.
Mm-hmm.
You've become family in many cases, or you know them better than family in many cases, and so you know when something has changed in their behavior or something's wrong. You also might be there when they fall and end up with an injury of sorts.
Okay.
So those are cases where it's really good to integrate with us, I think, and then follow your current protocol, whether that's calling the office directly and then the office can call us. Again, the idea is that we're just another option and something that helps to keep your clients at home rather than sending them out. It's not a great experience sitting in a waiting room of a hospital, or an ER bed is not comfortable.
Mm-hmm.
You have providers that are in and out really quickly, and we're on site for that 45 minutes to an hour providing that high level one-on-one care.
Okay.
So it's just a very different experience, I think.
You mentioned Denver Health. Are you guys billing Medicaid now, or just?
We bill Medicaid.
Okay.
Yeah, Medicaid, Medicare, and TRICARE, and
Okay.
then with Denver Health, they have their medical plan as well, which is a completely separate insurance plan.
Right.
Provided.
Okay.
Yeah.
What is the criteria from your perspective on where, I guess, the level of acuteness? Would it always be recommended to give you guys a call, maybe initially, or is there a stage where, obviously, a cardiac event, you're going to want to go ER, but is there some point, is there that sweet spot for you guys that you feel, hey, call us first before rushing to the ER?
It's a good question. I have a one-pager that I can send to you. It shows, so what it shows is the top 10 cases in which 911 and or an ER visit is necessary. So think stroke, GI bleeds, cardiac issues. And then for the remainder, it's call DispatchHealth.
Okay.
The nice piece is anytime you call us, you're always speaking with somebody who's clinical, who's making that triage, right? So we're not going to dispatch out if we feel like it's a case that needs a higher level of care.
Okay.
We don't provide transportation. We're not an ambulance. We're not coming, with lights and sirens. We're showing up in our tiny Prius, hoping that we can be your definitive source of care.
Okay. How do you guys fit in? A lot of times you hear, rather than go to an urgent care.
Uh-huh.
Do you guys see yourself, are you at that kind of pre-urgent care, or where do you guys fit into that whole model?
We're urgent care plus.
Okay.
So we can do anything an urgent care can and more.
Okay.
Many people have called us urgent care on steroids, or there's a lot of different terms. The reason why we're able to do more is it's twofold. So our clinicians to start have ER training, which is different than the training required for an urgent care. They're used to a higher level of acuity. And then what we've packed our cars with is the ability to do, like nosebleeds are a really good example. We see a lot of people with heavy nosebleeds. They can't get them to stop. Urgent care won't touch that.
Okay.
So those are, G-tubes, another big example.
Okay.
Oh, yeah.
Okay. Good.
Yeah.
Any other questions out there? Here's one from Wade. Can individuals come to a physical site for care?
We do not have a physical site to provide care. So the whole idea behind our model is being mobile, and that we come directly to you. So we would come directly to their home or their location of need. So if you happen to be at work, we've seen people at work that don't want to leave their office. We've come into the workspace and treated them if they feel comfortable with that. We've treated people at soccer field, so on and so forth, but not at our office.
Okay.
In fact, if you came in, there likely wouldn't be a clinical team there because they would be out treating others, and so it wouldn't work.
Okay. Any other questions? All right.
Okay.
Well, thanks, Melanie, for coming over. The document that Melanie suggested, we'll probably have that out on the website. I did record this, so if you have folks that you want to have maybe watch this as a form of reference, we'll have this out on our video library on our YouTube channel, as well as a link off the website. So please feel free to access that at your leisure. But thanks, Melanie, again for coming. We really appreciate it. And everybody have a good day, and we'll keep you in the loop. Next month, we'll have another People Talks like this, and we'll get the email out for that. So thanks, and have a great day.